I wanted to thank you for joining us. We're really excited about the global participation in this first webinar. We know that many of you are joining us individually. However, we are also very excited that several of our colleagues in 15 different countries have been very generous in organizing sessions, webinar sessions that can be attended jointly and together. So we are, there are 15 different countries, 15 different organizations who are hosting the webinars across the world, and we're pretty thrilled that we are able to engage so many people in this first webinar and hope that we can continue to grow the participation in these webinars over the next few months. I wanted to give you a sense for the agenda this morning. We have several speakers who are joining us today, beginning with Gary Newton, who will also serve as our webinar moderator. Mr. Newton, who is the Special Advisor for Orphans and Vulnerable Children for the U.S. government. Gary will provide us with a few opening remarks, just talking with us a little bit about the origin of this topic, the interest in this topic, why we chose this as our first topic to focus on during this webinar series, and why we believe it's important to learn lessons from our colleagues who are engaged in human resources for health workforce strengthening efforts. Next, our colleague Jim McCaffrey from CapacityPlus will provide an overview of human resource for health initiatives, highlighting both successes as well as challenges that have been faced throughout these initiatives. At that point, we're going to pause briefly for a few clarifying questions, and that's the point at which we can invite you to speak up using your microphones. But again, you may continue to write your questions, send them via chat or to my email address. After that, we're going to focus on an example of a global health workforce strengthening initiative, which will be presented by Estelle Quain from USAID, and she'll speak to us about the Global Health Workforce Alliance. Again, we'll pause for a few clarifying questions and then shift to a presentation on a promising local health workforce strengthening initiative, the Health Extension Worker Program in Ethiopia, which will be presented by Mengistu Asnake, and he is from the Integrated Family Health Program that is managed by Pathfinder International, and we're quite excited to hear about him. He's joining us from Ethiopia. Again, we'll have an opportunity to ask a few more clarifying questions, and then we're going to engage in a brief discussion during which we will provide an opportunity for those of you who are joining us throughout the world, and as well as folks here in the U.S. At CapacityPlus, to think about ways in which we can apply some of the ideas that we've discussed to our social service workforce strengthening efforts, and figuring out which of those are relevant and useful to the work that we're currently doing or hope to be doing in the future. We'll close with a few final remarks and also introduce our next webinar topic, which we're also very excited about. Just a reminder, feel free to write your questions or comments in the chat window throughout the webinar. I have also written my email address on this presentation, but we'll also read it out again just in case those of you on the phone want to email me with any questions throughout this webinar session as well. Again, my address is mmendenhall@usaid.gov, and we'll do our best to address your questions following the presentations. Great. So I'm going to hand over to my colleague, Mr. Gary Newton, who is our moderator and who will begin with a few opening remarks.
Thank you, Mari, very much, and good morning to many of you. Good afternoon to some of you. And good evening to our colleagues in Vietnam, if you all are out there as well. It's an exciting opportunity to interact and exchange views today via this webinar. I wanted to offer a couple of minutes of context, a couple of minutes of background before we get into the substantive presentations. As you all are very well aware, at the heart and the core of today's discussion are vulnerable children. Let me just say that you all are doing magnificent work on their behalf. We want to do more, we need to do more, and one of the core constraints to doing more on children's behalf is the workforce, the social welfare, child welfare workforce. The workforce is, as you all are well aware, comprised of good people playing vital roles on children's behalf, helping children who are abused, exploited, abandoned, separated, trafficked, subjected to violence, protecting children from these calamities, reuniting children with their family or finding good alternatives, keeping fragile families intact and viable, linking vulnerable children and families to services and benefits. But this workforce is not as strong as it needs to be in many of our countries, my own included. In some of our countries, this workforce is seriously underfunded and overworked. So the central hypothesis underlying this discussion today is that care, protection, and family support services for the most vulnerable children can't be significantly improved or expanded or sustained without strengthening the workforce. That's what we're here to talk about. That's the challenge we've taken on. So today's topic, as Mari has said, is social service workforce strengthening and human resources for health. Lessons learned from the global healthcare workforce. This topic was chosen to be the topic for the first webinar conference for a couple of reasons. One is the high level of interest expressed at the November 2010 conference in Cape Town that many of you attended. And the other reason is the high level of interest expressed in a survey that CapacityPlus conducted among all or many of you to get a sense of the priority topics you would like to discuss. This was number one. The other reason to begin with this topic is an obvious one, and that is that we have an opportunity, we need to take advantage of the opportunity to understand and apply the lessons learned from what is a 7-year-long effort on behalf of our colleagues in the health sector to strengthen the health workforce. We need to understand and apply those lessons to the younger effort that we're embarking on to strengthen the social welfare workforce. One of the ideas that has come up is to launch an initiative, a global alliance, if you will, a global alliance that would heighten the visibility of this social welfare workforce, that would improve appreciation of the workforce's value, and that would boost a workforce that after all embodies the values of social justice and equity. But before deciding on the structure, the mission, the mandate, the functions of such a global alliance, it of course makes great sense to learn from the experience to date in the health workforce strengthening effort, and many of you, of course, have been doing great work on that front. So in this webinar discussion, we're focusing on the health workforce strengthening experience to date, and the idea is to try to mine that experience, if you will, M-I-N-E, mine it for nuggets, for jewels that can guide us as we proceed with our fledgling initiative, our newer initiatives to strengthen the social welfare workforce. The two workforces, the challenge to strengthen them, have a great deal in common, of course, at the most fundamental level. Both workforce strengthening efforts involve advocating increased resources, financial and human, and system strengthening to improve the well-being of children and families. That is probably the most fundamental similarity. But as you're well aware, there are key differences between the two efforts to strengthen the health and social welfare workforces. The health folks work primarily in a single sector, the health sector. We, of course, work in multiple sectors. Their treatments and outcomes and indicators and targets are, with all due respect, clearer and more concise than ours, and consequently they have better data on unmet need, on the feasibility and effectiveness of interventions, on the cost of meeting needs and the cost of not meeting needs. So with those few words, dear friends, I will attempt to facilitate and attempt to moderate this almost global discussion. And at this point, then, I would like to turn over to our colleague, Jim McCaffrey, for the first presentation. Jim, over to you.
Terrific, Gary. Thanks very much. This is Jim McCaffrey, and as this says, I'm going to talk a bit about the HRH system strengthening work that's gone on over the past 7 or so years, and what some of the implications and lessons learned are in a more general sense. And we'll do 4 things. One is a very brief overview of the HRH crisis. Many of you, because it is a kind of related and parallel sector in your country, may be already familiar with it, so I'm not going to spend a lot of time on it, but I do want to highlight a few things. To look at the progress, to identify lessons learned for social welfare workforce strengthening, and to share some examples of relevant tools and resources, because picking up on what Gary said about mining the experience, and I would just add that the key message here is, where you can, don't start from scratch. Adapt tools and practices that your colleagues in the health sector have used, and collaborate and join with them as appropriate within your country when they're doing something that relates to your work. So those are the goals today. A couple of overall thoughts. One is an interesting statistic around healthcare, and that is over 1 billion people never see a skilled health worker during their lives. Second thing, in 2006, and the reason for this is that there's simply not enough healthcare workers in many countries. And in 2006, WHO published the World Health Report on human resources for health. And in that report, they identified 57 countries with a health workforce crisis. And by using a ratio to look at certain kinds of health outcomes related to the number of workers per thousand, and the ratio was 2.3 healthcare workers per thousand, which was the sort of bottom line or borderline target that should be there in order to have reasonable health outcomes. And there were 57 countries that fell below it. Some fell well below it. 36 of these 57 countries were in sub-Saharan Africa, and you can see the others outlined on the map. So there is a continuing health workforce crisis. And what are some of the issues? One is, as mentioned, an absolute shortage of healthcare workers on a country-to-country basis, and we're talking physicians, nurses, nurse midwives, and then a number of allied health professionals, pharmacists, lab techs, and community health workers. Secondly, there's inequitable distribution, especially with physicians, but also related to all of these other healthcare workers. That the healthcare workers tend to be located in more urban areas, and there is a chronic problem of attracting and retaining healthcare workers in rural and hard-to-reach places. Third, there is a migration issue that, especially at the physician level, where there are opportunities on a global level for physicians to migrate to work in different countries. That has been a problem, and there's now also a flow problem within countries where healthcare workers may flow from the public sector to the private sector to the NGO sector, from the faith-based sector to the government sector based on changes within compensation issues and changes in kind of work environment. There are weak human resource management systems that sort of plague the sector that often have very concrete outcomes. For example, if you look at recruitment and hiring, in many countries it takes 9 to 12 months from the start of a recruitment process till one can finish a position. It's a long time. People apply, they often drop out by the time they get around to being offered a job or they've moved on. That often results in the ministries of health actually not filling the obligated positions they have, and they end up turning money back to the Ministry of Finance, and that weakens their case for arguing for more money for more healthcare workers, because the Ministry of Finance says you don't even use the money that you do have. So these are very concrete outcomes. There's often a poor work environment at the site level, with inadequate supplies, tools, technology, and even basic sort of a site, a building. And lastly, there are issues related to advocacy and leadership, both at the country level and somewhat globally. That is, there have been progress in all of these areas, but there still remains space for increased leadership for human resources for health and increased advocacy to get the kinds of resources, both human and financial, to solve this particular crisis. What's been the progress? There really has been, over the past seven minutes, excuse me, over the past, I just got a little sign that said 5 minutes. Thank you. There have been various global and country level initiatives. We're going to hear about a couple today with the Global Health Workforce Alliance presentation with the example from Ethiopia. But multilateral donors like WHO, multilateral organizations like the Global Health Workforce Alliance have made a contribution both globally and at the country level. There have been bilateral organizations. USAID has been, and PEPFAR have been a big funder of initiatives at the global and regional and country level, and that's made a big difference over the past 7 years. Some of the things that have happened: there are now HRH strategic plans in about 46 of the 57 crisis countries, and that means that they've done a situation analysis and they've thoughtfully outlined a strategic plan for addressing gaps. There are still now issues with implementation of the plans, but certainly the progress has been made in trying to make that more strategic and use that as a foundation for planning. Dealing with the hiring example I gave, in at least 3 or 4 countries, they've taken on emergency hiring processes where they've cut that time of 9 to 12 months down to 2 and 3 months by trying to streamline the processes and by having public partnerships. There have been various ways that they've tried to produce new health workers in shorter time periods. Health workers that may actually take on new tasks or tasks that more experienced or more senior health workers were taking. And we're going to have one example of that with Ethiopia and the health extension worker activity in Ethiopia. HRIS stands for Human Resource Information Systems. There's been a heavy investment by USAID and by the CapacityPlus project and Capacity in strengthening the basic human resource information systems that are out there, so that there's a much better idea about which healthcare workers are where are their vacancies, where are their issues, and where are their program problems. And then there's been a range of helpful tools that have been developed, many of which I think can be used or adapted by the social service strengthening effort area. And I'll mention a few of those in a minute. I think that as we look at the lessons learned that are applicable to social welfare workforce strengthening, one is that first one, and it's in blue. I think one of the things that we've learned is that strengthening the workforce is a long-term issue. It's not something that's going to be solved very quickly. It takes a sustained effort, and it takes the partnership at the country level, certainly in the HRH area, and I think in the social welfare workforce area, because it often involves several different players, several different ministries, different sectors. It involves cooperation with public and private and NGOs and FBOs, and so because you have to marshal all these people together, it takes longer. Sometimes the education and training takes longer to produce enough. The interventions that people make to keep people in place take longer to achieve results. So it's a long-term issue, and we will just sort of recognize that. Advocacy remains an issue, and it's advocacy related to basing further arguments for further resources on results that an increased healthcare workforce can produce. Third, there is a kind of an emphasis on a holistic approach needed. That doing things that are one-off interventions often don't work. Fourth, I mentioned in the long-term issue that partnerships need to be established and maintained at all levels, and that there are adaptable tools for the sector. Now, I will give you a couple of examples of the tools. There is a community health worker report that the Global Health Workforce Alliance produced that I think has a lot of relevance for social service workers in rural areas. And there's a lot of overlap between what community health workers do in some cases and what goes on in the social service area in rural areas. Second, there's a retention report that WHO has produced and launched last September, which has a good deal of material around how to attract and retain people in rural areas, and I think it has, again, relevance to this. We've produced stakeholder leadership guidelines that will help in the partnership area, and WHO and PEPFAR has produced task shifting guidelines. That's the wrong direction. And then here are a series of websites, and you will have access to this PowerPoint afterwards, so you can go on these. You already have the first one, the OVC Support Net, but the WHO website, Global Health Workforce, and the HRH Global Resource Center are also very important websites and very good resources. I think that's it. That is it.
Thank you very much, Jim. Excellent presentation. Ladies and gentlemen out there, we have 10 minutes for questions, comments, discussions. And the first question for Jim McCaffrey is, how did WHO arrive at the 2.3 health worker ratio?
It was a research project basically, and it involved a number of people gathering data on a global basis in Geneva, and looking at there were 2 or 3 particular, I don't know if you remember, Estelle, 2 or 3 particular health outcomes, and then linking the metadata to those particular health outcomes. But there is a really good description of it in the World Health Report from 2006, and that is available online at that WHO website. And I would encourage people that want further explanation of that to go to it, because again, that kind of evidence and research could be very helpful for you all too. Back to Gary.
Thank you, Jim. Other questions, dear friends? Another question coming in over the teletype right now is, what are some of the findings from the retention report that was mentioned as an example of a tool?
Hello, everyone. This is Estelle Quain from USAID. Myself, as well as Jim McCaffrey, were members of the core group of experts which helped with the development of the retention guidelines at WHO. It was decided to include guidelines under 4 different areas that were relevant to healthcare workers. One had to do with their education. Another had to do with regulation. A third had to do with finance and incentives to motivate healthcare workers to remain in remote and rural areas. And a fourth had to do with professional and social environment support. We were looking at what types of things influenced the motivation of healthcare workers to go to and remain in remote and rural areas. And we did an evidence-based literature search, which came out with anywhere from 2 to 5 recommendations under each of those 4 areas. Basically, you know, overall, when you look at something this broad, you have to remember that each of these recommendations has to be looked at within a particular country context, and some of the follow-up work that WHO is doing since the recommendations were published last fall is taking them to countries in different regions and seeing how they could be implemented, trying to come up with which combination of them would help these interventions work, because we realized that it wouldn't be enough to just, let's say, design courses to educate rural healthcare workers to the needs in rural areas. Yet that's one recommendation, but it needed then to be combined perhaps with some of the physical infrastructure that healthcare workers were going to be finding in those areas and the psychosocial support that they themselves would be able to have. So that would come from another series of the recommendations in the report. So it's a complex series of motivational factors. The guidelines report is, the retention guidelines report is a very interesting report to take a look at, and you can also get that on the WHO website.
Excellent. Thank you very much, Estelle. Excellent questions coming in. Let me pose the next one that has been sent in. And the question is, how do you ensure quality of the trained health worker when using a short training period? For example, the example of Ethiopia and that question is from the Zambia team.
Great question, and I think what we'll do is leave the Ethiopia example to Mengistu, and he could take a look at that when he explains more about that, because that's a very good question, and he's listening in on that and will be able to address it. I think the quality issue comes down to, especially when shorter programs, is being very clear about the competencies that we're trying to train people in order to perform certain functions. And then, because there's been a traditional education and training in the health sector, which was often very academic and often not directly related to some of the tasks that need to be performed, especially as you move into more rural places. Where there are things that community health workers can do, or things that nurses or nurse assistants or clinical officers that could do that previously may have been only done by physicians. And so what has happened is, in there are various examples of this where people have looked at certain competencies and designed shorter programs just to perform those certain competencies. And there was a recent study that came out about 9 months ago around community health workers, and found that given the right support and the right clarity and the right training to perform these competencies, they perform them as well, or in some cases better than physicians or nurses. So there's a lot of good evidence in this about that. And again, that's available in an online HRH journal published by WHO.
Excellent. Thank you, Jim. Here's a question that has come in, a request to offer some specific examples where advocacy has worked, specific examples of effective advocacy approaches, effective in terms of leading to strengthened human resources for health at the country level. Could you offer a couple of specific examples?
Yeah, this is Estelle Quain. I'm going to give you an example. First of all, I think it's important to say that the Global Health Workforce Alliance has been working specifically as one of the major advocacy organizations for human resources for health. And the Alliance was very much behind putting together background and mounting advocacy efforts for what's called the Global Code of Practice on the Migration of Healthcare Personnel. And I don't know if any of you by chance were following this, but it was quite an effort to come up with the current code of practice, as it's called, through the last year's World Health Assembly finally approved a code of practice that all the member nations could agree on. But the migration issue is, of course, a tremendous issue for highly skilled healthcare workers, for those of us working in this field, because highly skilled healthcare workers are easily called upon and easily enticed away from their jobs in resource-poor areas to countries in the developed world, like Britain, the United States, Australia. We have some of the, I think, largest role in accepting healthcare workers from sub-Saharan Africa, particularly, who are interested in migrating for better opportunity. Well, this was an area that there had to be a lot of advocacy about from developing nations, from groups like the Global Health Workforce Alliance. And it's one example, I think, of how an advocacy effort has worked on the global level, and with an influence, therefore, at the country level, because hopefully it would have an impact on the numbers of healthcare workers that choose to stay in their countries as opposed to go to others, where perhaps their services are needed, but not as much so as in developing countries. I'm trying to think of another.
We won't talk a lot about this, but that advocacy question, there are several examples of the advocacy around compensation issues at the country level. And I think there have been examples in Ghana, Kenya, Malawi, and Zambia where different kinds of groups and different associations have advocated for higher compensation for physicians and for nurses to meet certain kinds of goals, and there is a range of kind of literature around that, which, if you're interested, again, I think some of that is part of the WHO retention report, where they summarize a lot of this. So let me wrap up this section of it. So this is a sort of overview around the HRH sort of issues, progress, and potential tools and resources, which we've gone over somewhat in a kind of a hurry, but you will again get this PowerPoint and you'll be able to pursue on your own, and would highly recommend it because some of these tools have very direct relevance.
Great. Thank you again, Jim and Estelle. At this point, the questions that we couldn't get to, we can save them up and return to them during the discussion period in a bit. And if we don't get to them at that point, then we can offer written responses and comments in the days to come, post-webinar. A question did come in, which is it always comes up, frankly, and it's a good one. And the question is, how do we define the social welfare workforce? So let's just pause for a moment, and I want to read a paragraph that is in the report on the Cape Town Social Welfare Workforce Strengthening Conference, and it's under the section on definitions. So let me just read that, and let's use that, if we may, for the purposes of this webinar discussion. And that paragraph reads, the term social welfare workforce was intended as an inclusive term describing the broad variety of different workers, paid and unpaid, governmental and non-governmental, that presently make up the workforce. Social workers are called by different titles in different countries, including but not limited to social workers, parasocial workers, child and youth care workers, community development workers, and child and family probation officers. So if we may leave it at that for the time being, and with your permission, we can move on, and I'd like to introduce our colleague Estelle Quain, who is going to present on the history, mandate, and challenges of the Global Health Workforce Alliance. Over to you, Estelle.
Hello, everyone, again. I'm happy to have a few minutes to talk to you about the Global Health Workforce Alliance, which is called by its acronym name, the GWA, the Alliance, better. The Alliance was actually formed to be, above all, an advocacy arm on human resources for health. It sits within WHO as an independent organization within WHO, and it works together with the HRH department in WHO. So it's important to keep in mind that it is, by and large, a global level organization, and that it has a special additional function to the established HRH department at WHO. By means of history, I can start by showing you a slide of a very important document that was published in 2004. It was funded, the Joint Learning Initiative was an effort of about, well over 100 experts and interested professionals in human resources for health. They got together to consider the crisis, which everyone was beginning to realize existed, especially with the rising influence of the AIDS epidemic. And it drew attention to many of the issues that Jim has already talked about. Some of them they're summarized here on the left. But this document really was the foundation for pointing out to everyone, there is an HRH crisis, and here are some things that we can do about it. Jim also mentioned the World Health Report of 2006 with this map, which we see in many places already, pointing out the 57 crisis countries. I'm mentioning it again because of its importance within a lot of the work that's being done on human resources for health and the impact that it has on the work not only of WHO, but of the Global Health Workforce Alliance itself. This next slide gives you a quick summary of the Alliance's history. And I think here we can take from it not so much what's in every box, but just looking at this trajectory. The GWA was launched, is that first box on the top on the left, in May of 2006. The JLI report appears on the bottom, and the WHO World Health Report of 2006, also on the bottom, coincided more or less with the start of the GWA. And it's important to look at what the GWA has done across the top of that timeline and how it has influenced the activities, the key activities, many of which are GH summits or UN special assemblies on different diseases, where the GWA has advocated and made technical presentations at these meetings to continue to keep the HRH issue on the agenda. And I think that that really has been the GWA's function above all else, and it's been very successful in doing that. Way on the bottom, you see the board chairs and the executive director just since 2006 when the organization was started. But I think it's the interplay between the bottom and the top line that we need to keep in mind, that the GWA, more than anyone else, has kept its eye on these global level meetings like the G8 meetings, and how do we remind policymakers at those meetings of the importance of human resources for health. As I said, the GWA has some very special roles to play. Its vision is access for all to a skilled, motivated, and supported health worker, which we know is a pretty daunting task given the fact that Jim mentioned that about 1 billion people have no access to skilled healthcare providers. And its mission is to advocate and catalyze global and country actions. While the Secretariat of the GWA sits in Geneva, it does not have permanent staff in country, but it reaches out, and this is where the GWA works very closely with WHO, through WHO representatives in countries to carry out activities which will draw attention to the importance of HRH and which will mobilize action from the various players in country to look at how the HRH crisis needs to be addressed. It is a membership organization. It has 335 members and 29 alliance partners. All of this appears in more detail on the GWA website, which is ghwa.org. So one of the most important things that the GWA did in 2008 was to organize the first Global Forum on Human Resources for Health. And that was held in Kampala, Uganda, February of 2008. And out of that meeting, which brought representatives from all over the world, two important documents came out which continue to be cited. One is the Kampala Declaration, and the second is the Agenda for Global Action. The strategies of the Agenda for Global Action are on this slide, and we've talked about some of them already. The leadership piece, the informed response piece, which has to do with the HRIS and human resource information pieces that Jim mentioned. Education and training is a critical piece. We all usually think only about education and training when we think about developing the health workforce, but we also need to think about retaining that workforce. We need to think about their migration, as I mentioned before, about the code of practice, and how to manage, in quotes, that migration as well as we possibly can, if we can. And finally, to look at the funding. So it's those 6 areas that the GWA has led its efforts in continuing advocacy. But it works really under 3 functions, with 3 functions, A, B, C, advocacy, brokering, and convening. So the advocacy function, I've talked about some. Yes, please. Sorry. The advocacy function, I've talked about some. The brokering function is very important as well. The GWA has developed some technical task forces on key issues and has then brokered that knowledge, has brought together experts to develop that information, like the Community Health Worker Task Force and report that Jim mentioned. And finally, the convening function, like the first Global Forum on Human Resources for Health that I mentioned, and there was a second forum on Human Resources for Health held in Thailand this past January, which had more than 1,000 participants from many, many countries. So we are now 5 years into the GWA's existence, and we're really at a critical juncture. There have been significant achievements, and some lessons have been learned in the first 5 years. More details to follow because an external evaluation is currently being undertaken to look at exactly what we have, some very good ideas of what we've accomplished, but to evaluate those accomplishments and to see where we should be going in the next 5 years. The GWA has developed a strategic plan for every year, and the 2012 plan is currently under development. There are a few challenges which I may have made reference to already, but I think that if this group, if those of you interested in the social service workforce decide to go ahead and decide that you would push for a global organization like the GWA, I think that there are some things that you really need to pay attention to and that the GWA has had to pay attention to. And one is data collection and utilization. Know how many social service providers you have out there. You know how to name them just now in the definition, but where are they? How many are there in each country? How many more do you need in each country? These are the types of questions that we've been struggling with and are finally beginning to get some answers for in Human Resources for Health. You need to engage champions with global influence. I think that this is really how the Global Health Workforce Alliance, at least, was started. It came out of the effort of certain global champions that led the Joint Learning Initiative and led the production of the World Health Report. So really recognize champions in your field that are going to hang in there for a while are very important. The advocacy function is critical, and if you go to the GWA website, you'll find a lot more information on the types of advocacy that they've done through their members and other partners. And finally, sustaining funding. I guess it's no secret that WHO itself and the GWA particularly are in a funding crunch for this fiscal year. They're about $4 million short. So it's one thing to get a lot of enthusiasm going at the beginning of an effort, but you need to figure out and keep in mind how are you going to sustain that, along with the champions both at the global and at country levels that you need to have involved. So I just wanted to give you all some idea of where the GWA is, where it came from, where it is now, and what major things you should be paying attention to if you're interested in going the route of setting up an international alliance like the Global Health Workforce Alliance. Thank you very much.
Thank you very much, Estelle. That was a very, very nice presentation on the Global Workforce Alliance and WHO's Human Resources for Health. A question has come in that is sort of a fundamental question that we could discuss for a minute, and that is, given WHO's definition of health, famously is a holistic definition that includes social well-being, and given that the Human Resources for Health effort within WHO seems to be focusing exclusively or primarily on health workers per se, what would your off-the-cuff remarks and advice be with respect to the advisability of working with WHO's Human Resources for Health group to have them accommodate, to include in their mandate, in their scope, social welfare workers as well as health workers?
Well, I think we've approached WHO about this. We're beginning on a number of levels, and we haven't gotten an immediate yes, to be quite frank. But I don't think the door is totally closed, and I think that we need to continue to dialogue, particularly with GWA. It would be fantastic if we went to the GWA and said, here's a couple $100,000 for you to investigate the social service workforce, I do not think that they'd shrink from that. Because really, if you look at the WHO definition of the health workforce, social workers are included in there, if I'm not mistaken. And the Global Health Workforce Alliance itself, as I said, accomplishes both its technical and its advocacy work through task forces. And I think that if we went to them with a ready-made task force and some funding to support that, which is critical given the current fiscal situation at WHO, I think we might get some positive response. Jim?
This is Jim. Just to add one further thought. This is, Estelle was talking about the global level. I think these are very good ideas. At the country level, many of you have sort of working groups that include USG, UNICEF, and then colleagues within the country. I would encourage you to actually go to the WHO rep in your country to talk with them about this very issue, because often they do have small amounts of seed money to contribute to the kind of dialogue that needs to go on around this. So I would really encourage you to do that.
Thank you. Another question has come in. It's a good one, and it relates to the interaction between global advocacy efforts and country-level advocacy efforts. Basically, how do we leverage global advocacy with sustained in-country advocacy efforts? Because that question would apply specifically to the experience of GWA and HRH and the interaction between a group that is, I gather, based mainly in Geneva, and then networks of leaders and champions working on behalf of the health workforce in primarily or exclusively the 57 crisis countries.
There are also regional organizations that work on human resources for health and that coordinate their activities with the Global Health Workforce Alliance. One of those is the Africa Platform that is based in Nairobi, I think now, or we can get you more information on that. But also, not if you happen to go back to the slides I showed. On the bottom half of that timeline, there's an organization called AAAH, the Asia Pacific Action Alliance for Human Resources for Health, which was founded soon after the Global Health Workforce Alliance in the Asia Pacific region by another group that was interested. Also, there are observatories of human resources for health. This is an idea that was generated out of WHO, but which has taken on life at regional level with the help of WHO. And Jim is going to say a little bit more about that.
Yeah, I just returned from a global conference of these observatories. Their purpose is to make the best use of increasingly available workforce data and evidence and have that inform policy and decisions and actions at the country level. And this is a very good example of something as a global support from WHO HRH has regional observatories in each of the 6 WHO regions, and then has country-level observatories in many countries, not all countries. And so they share that kind of information, especially between the regional ones and the country-level ones, where they reinforce each other's work at both advocacy and also better use of data for decision-making. And then they try to extract from the country level so that they can begin to make regional comparisons. And so this conference that just happened last week was a way of creating South-South dialogue about all this.
I think we have time for one more question. And that question, again, relates to organizing at the country level to strengthen the social welfare workforce. What has the experience been, or what advice would you have to colleagues who are working to strengthen the social welfare workforce on with whom to partner, with whom to coordinate, what mix of organizations and entities at the country level seems to have worked well in terms of strengthening the health workforce that might be enlightening for the social welfare group to hear about. Jim?
Good question. Let me, I'll take a case example of Ghana that has just, I just talked with the chairperson of their HRH observatory, and they have 25 members in it, and it involves a combination of several ministries, all of whom impact on the human resources for health situation: Ministry of Health, Ministry of Education, Ministry of Finance, Ministry of Local Government, and the Civil Service Commission. I can't remember if that's the exact name. It also has FBO representation. It has representation from some of the professional associations. It has representation from 2 or 3 key medical schools. And I'm probably forgetting this, but it's this group of people that are meeting, and they're right now engaged in 2 things. One, revising an HRH set of policies that will make it easier for several different changes to occur within the health workforce. And secondly, looking at pre-service education, trying to make that revisions in the curriculum to do that, and to make it also more relevant to the diversity of places that exist within Ghana. But that's one example, and it does have some support as it goes and it does its work. And so I think what the issue is to take a look at, once you have a good idea of what the workforce situation is at the country level, both the formal and informal workforce, you then have to figure out who are the major stakeholders that have an impact on that workforce, and then get them together. And I know that that's happening in some countries already, and I would just advise that the more inclusive you are, without making it too complicated, the better off you're going to be in the long run, because all of these players have the capacity to either help or to get in the way of reforms.
Good, thank you, Jim. Now turning to the next agenda item, and again, keeping in mind that the overall goal of this first webinar is to learn from the experience of our friends in the health sector in terms of strengthening the health workforce. We have the privilege to turn to Mengistu Asnake, who is with Pathfinder International in Ethiopia, and he is going to brief us on Ethiopia's successful effort in increasing the health workforce at the community level. So, Mengistu, over to you. Kindly remember to engage your microphone.
Thank you so much. Can you hear me? First of all, good morning for my colleagues across the Atlantic, and good afternoon for those joining from the other side of the world. I will try to briefly present on the overview of the health extension program in Ethiopia. I'm Mengistu Asnake, working for the Integrated Family Health Program, which is a flagship program USAID funded on family planning, maternal, newborn, and child health in Ethiopia. I'll briefly go on the background, the health extension program itself, what are the major achievements and the lessons learned from the program. In terms of Ethiopia, it's the second most populous country in sub-Saharan Africa, the first being Nigeria, having a population of close to 80 million, and most of the people living in the rural area, almost close to 83%. The next slide, living in rural areas, and almost 45% under the age of 15 years, a very young population. Ethiopia is a country with a very high fertility rates, with high burden of maternal and childhood disease and death. So having all these problems, there is a need to see better mechanisms of managing its problems in terms of improving the health services, primarily in the rural area, but overall in the country. In 2005, in the next slide, the health sector development program, within its first cycle, tried to do an assessment and tried to look in terms of where are we. In most basic health services, they didn't reach to the needy population at the grassroots levels. This is primarily because of most of the health services, like the health centers, hospitals, these high-level facilities were primarily either in the urban, peri-urban areas, or in places distant from the most needy people at the grassroots level. The other issue is with limited resource, there is a limited expansion of facilities at the rural areas. So having the lack of basic health services and also limited expansion of facilities, there was a fundamental gap in applying the core principles and practice of primary health care, where I have already explained 83% of the population lives in the rural areas. Again, the uneven distribution of facility-based services, even earlier described by Jim in terms of a global problem related to critical shortage of the workforce, both in, overall in the country, but specifically in those rural areas. Having seen all these problems, several actions were taken, which were included in the Health Sector Development Program 2 and 3, including the development of different strategies, including the child health, reproductive health, and others which were planned to support the expansion of health services in the country. But above all, the decentralization of health services, including the initiation of the health extension program. But prior to that, the most development partners, including organizations like us, were implementing voluntary community health services. These voluntary community health services had their own challenges, specifically in terms of sustaining issues like in Ethiopia is like reaching grade 10, and they took a 1-year training on basic preventive, promotive, and primary curative services. 98% of them are female, and the government has a specific strategy. First of all, the females can respond better in terms of most maternal and child health problems at a household, at the grassroots level. But additionally, the government took, this is part of empowering women by creating an employment opportunity for such huge number of health extension workers. They were selected from their own community. If someone who could not fulfill the criteria is not from that community, then they can be found from the same district or warada in the case of Ethiopia. Once they finish the training, they are paid by the government, and 2 health extension workers serve 5,000 people as a grassroots level community provider. Normally, the 2 health extension workers are supported by volunteers. In principle, the program is institutionalizing a standardized village healthcare delivery as primary healthcare unit, which means 1 health center with 5 villages or 5 health posts serving as a primary healthcare unit, and the health center is a referral unit for the health extension workers. And this is like 5,000 people in each village. So for the 5 health posts with 10 health extension workers, there will be 1 health center, which is almost like 25,000 people accessing the services. Basically, it's to increase an access to and utilization of promotional, preventive, and essential curative services at the grassroots level. And the principle is empowering the caretakers and the community to produce their own health through model families and also communities. One issue which is there is the Ethiopian government took the experience of the health extension program from its agricultural extension program. If people can produce better agricultural products through the extension program, why not health? So certain experience were taken from the agricultural extension program. Families are trained for close to 96 hours in terms of the 16 health extension program package with frequent household visits by the health extension worker. The health extension workers are expected to do 70% of their time in household visits and 30% of it to stay at the health post to provide some of the preventive and essential curative services. Model families who are trained for 96 hours, if they practice 75% of the package, which I'll show you in the next slide, then they'll graduate as a model family. And those who are active enough become volunteers and they diffuse the health practice to their neighbors. As you can see from the slide, there are 16 packages, but in terms of, they are divided into 4 major areas. In the area of family health, in the NCH area, if I can give you an example, they are providing community case management for common childhood illness such as malaria, diarrhea, and pneumonia is a recent introduction into it. They provide different methods of family planning at the community level, which includes condom, pills, injectable contraceptives, and the past 2 years, the government decided to introduce the one-roll implant at the community level by health extension workers. So they provide immunization, nutrition, education, and services, adolescent health, in the disease prevention area, HIV, TB, malaria, and first aid are the most important one, hygiene and environmental health in terms of personal and environmental hygiene, including water and sanitation. In the health education and communication, it's a cross-cutting across all the different components of the health extension program. What are the major achievements? Starting from 2005, it was possible to train over 34,000 health extension workers and deploy are trained for 3 months. Sorry, there was a discontinuation. In the rural health extension program, these are grade 10 graduates, but in the urban health extension program, these are nurses trained for 3 months to serve in the urban area. So the other thing is there is an increased level of awareness on healthy behaviors at the community level, which is also linked to increased access and utilization of most promotive, preventive, and primary curative activities at the grassroots level. By doing this, we have a lot of increase in coverage in most primary health care services. But one of the questions which was even raised earlier was the issue of creating a linkage to referral services. So it's not only strengthening the health extension program, but the government is working towards also increasing health center expansion, creating a referral linkage to the health centers. So in doing that, there is also a parallel and simultaneous initiatives going on in terms of increasing other services which are required to strengthen the grassroots level activities. Additionally, a supervisory system is built through the primary health care unit where the health center is responsible to follow up for quality and other issues related to the health extension program. If we see some of the issues like one major important thing is there is a community ownership of the program. One is like the model families by becoming volunteers, and one of the principles is model families, once they have a high level of practicing the behavior, they will act as diffusing to their neighbors. First of all, to be a model, they have to practice themselves before they go as volunteers to their neighbors. If you see few factors or few activities which we did between model family and non-model families across 700 households which are model and 700 non-model ones. What we found out is you can see in the graph that there is a huge variation in terms of having a toilet ownership and utilization between those model families and non-model families. Looking at like other factors, in the end of 2009, the JSA LTNK project did a trend analysis in terms of use of family planning, which is seen in the next slide, where in 2005, the DHS showed that there was a very high rate of use of family planning. As you can see, the DHS in 2005, health center use was almost 62% compared to 29% in 2009. The reverse is true. At the health post level in 2005, it was only 13%. Now it's almost 59%. This clearly shows that when we increase access at the grassroots level, people are starting to use the services rather than traveling to long distances to get the services in the health centers. So by doing this, there was a decrease in the opportunity cost, and by decreasing opportunity cost, people can do their routine activities and can go to the nearby facility to get the same service where they were getting it in the past from a distant facility. Another area is we try to compare between model families and non-model families in terms of family planning use, and what we have found is a very significant difference in terms of current between, in the next slide, where 32% of model families using family planning versus 18% in the non-model families, which is also significantly shown in terms of some of the methods which are being used in the model families. One area which is also raised as a question is, being a model family by itself, I mean, practicing is an incentive for them, because one area is the model families, by practicing those things, first of all, they will get a recognition with a graduation in the community. So that recognition in the community will give them an opportunity for them to continue to practice, but also work with their neighbors in the activity. In the next slide, we can see that what are some of the lessons learned in this program. First of all, the health extension program. The next slide. The next slide. The health extension program scheme is creating unprecedented opportunity to strengthen community-based service delivery, and it also created an opportunity to increase access to primary health care at a community level. The other lesson, the next slide, the other lesson is it's creating an opportunity of a great community ownership. For example, in the community, the health post construction, is done specifically for local materials by the community themselves. So the whole issue is the community contribution is showing you that there is a problem in terms, there is an issue that the community needs those services from the health extension program, and they are contributing a lot in terms of, one, supporting the health extension workers, also putting resources for the construction of health posts and other materials which are needed. Next slide. The other thing is different innovations are being created at the community level. In terms of innovations, from community to community, there are various innovations which we are looking at that one. For example, in keeping the sanitation within the community. People are even doing social sanctions. If they get people using open field defecation, then they are using social sanctions where people don't want to get into those social sanctions and keep their environment clean beyond personal hygiene within the household level. Again, one of the lessons is there is a need for a proper monitoring and referral linkage. That's why the government put already the supervisory structure and also the primary health care unit with the health center. That's one thing which is going on. One lesson which we learned is in the past we were doing these types of activities through community volunteers in limited districts, but currently the government initiative is a national impact through a blanket coverage in order to bring about those targets within the MDG. Doing only excellent activities or model activities in limited districts or in limited regions will not bring about a national impact. So through that understanding, then the government put clearly a budget to support the health extension program, and development partners are also participating in this program. I think briefly, this is what I just wanted to present on the experience of the health extension program. Sorry for the internet problem, for the discontinuation. Thank you so much.
Mengistu, thank you very, very much. And congratulations for your good work. A couple of clarifying questions have come in. Two are related, so I'll ask them together, hoping that you can hear me. What are the criteria for selecting model families? And what support or incentives do the model families receive? Hope you can hear me.
Thank you so much. First of all, the model families, first of all, every household in the village will undergo the 96 hours or a 3-month training by the health extension worker in terms of those packages. So by going that package, after the 3 months, if they practice at least 75% of the behaviors within the package, then they will be graduating as a model family. So among those model families, those who are willing to be part of the diffusion of their practices to their neighbors and others will be selected as volunteers. But to be a model family, they at least should practice 75% of the package. In terms of incentives, first of all, when they become a model family at a village level, they will be given a certificate and the recognition at the community level. So that's one of the major incentives for them. Other than the recognition, there is no financial or other incentives. In the past, before the health extension workers, those activities was primarily done by volunteers. Now, the government puts salaried health extension workers, and the volunteers are not engaged into like a day-to-day or routine activities. Just recently, the government introduced what it calls a health development army, which means one volunteer working with 5 households in order to minimize the amount of time for a volunteer to go to like 25, 30 households. So 1 for 5 is one of the principles which is going on now.
Great, thank you, Mengistu. Questions keep coming in. Your presentation has generated a good deal of interest. The next question is related to how you all have addressed the question of quality in a training program that appears to be relatively short. I think your slide said it was 96 hours for the model families. How to ensure and guarantee quality?
Let me first of all explain. The model families are not primarily service providers. The model families are primarily to communicate doable message to their neighbors. But the health extension workers who are primarily 2 health extension workers deployed in a village with an average of 4,000 to 5,000 people are trained for 1 year. And these are high school graduates, and they are paid by the government, and they are put under the payroll of the health center. So in any training with the health extension workers, for example, I can give you the example of the implant training or the one-road implant training for health extension workers. It's always a competency-based training. So before they finish that training, they have to have a certain level of competency which relates to the quality. But in addition to that, there is a continuous follow-up visit from the health center, one health center managing 5 health posts or 10 health extension workers. So the health center is a backup for the health extension program as a primary healthcare unit.
Good, thank you very much. Let's ask a broader question, if we may. Questions have come in related to the process followed in Ethiopia that led to the government's decision to presumably fund in a sustainable fashion a cadre of 34,000 health extension workers. What was the process in terms of advocacy? What led to the political, if you will, the government's decision to embark on that course?
First of all, the issue is like most of the health problems at that grassroots level are easily preventable with, first of all, with health promotion. The second thing is with simple intervention and also with primary curative services, which may not need a very highly skilled health personnel to do that one. That's one. The second thing is with the community volunteers with several programs, community volunteers for family planning, community volunteers for malaria, community volunteers for water and sanitation, for TB program, which were there for years, probably prior to the introduction of the health extension program, clearly showed that they can be effective if they are continuously supported. But as a volunteer, you cannot expect them to stay there for years and years without getting motivation or incentive. So the government looking at that, and also the development partners working together with the government. And as I have already said earlier, the experience from the agricultural extension program where having the development agents from the agricultural extension program in the village helped in a lot of places to improve the agricultural production. So the question came, if we can do in agriculture, improving the production, can we do the same in health? So these are some of the things. So it all emanates from, I think, the years of voluntary work, but additionally the different partners doing the advocacy work, and also experiences in a small scale in the district level which showed change, convinced the government that this needs to be done in a larger scale, in a sustainable manner, with the government's input into the program.
Excellent, thank you. Mengistu. Now another question related to the role and functions of the health extension workers, sort of a two-part question. First, do health extension workers include any social welfare services in their mandate and their responsibilities? And secondly, how do health extension workers interact with community volunteers? And do they supervise, do they actually supervise community volunteers?
Okay, there are two things into it. The first thing is the health extension worker. I mean, when we come to the definition of health, there are a lot of social components into it. I mean, when you talk about, as an example, the water and sanitation issues, which has a lot of contribution into the health status of individuals, family, and community, there are a lot of mobilization activities going on that. In some communities now, there is 100% coverage of individual traditional pit lodges at a household level with a very high level of utilization. But they didn't stop there, because there are park buyers within the community which needs to use communal latrines. In order to do that, they need community mobilization, because individuals may not do communal latrines, but communities come together to do those social services. The other example is like, for example, the HIV/AIDS related, like supporting orphans or people living with HIV. Some even do innovations of like producing grain bank, where they contributed grain in a central place and use that one to support those who are in need. So there are different, because of the activities they do. I mean, they interact with religious leaders, they interact with community leaders, and they use a lot of community mobilization activities, which help them not only like having like the specific health service coverage, but social mobilization to do other social activities, which in one way or the other improve the health activity. In terms of the volunteers, they have different mechanisms. The first thing is when they do the training, because I said 70% of their time relates to house-to-house visits, and their 30% time is to in the health post to provide, I mean, facility-based services. So they have a lot of interactions with the volunteers when they go to house visits. The other thing is periodically, like in some places every 2 weeks, in others every month, they have a community meeting with the volunteers to discuss some of the issues related to the progress, some challenge, and how to solve it on that one.
Excellent, thank you. The questions continue to come in. As I think you all can see in the chat box, there are a lot of good questions.
Yeah.
At the conclusion of this session, Mari will suggest a way that we can address those questions post-webinar. So at this point, let us ask you, Mengistu, a final question, if we may, and then we'll turn to the final agenda item.
Okay.
The question is, how long did it take to train 34,000 health extension workers, and is there a plan to continue training those health extension workers? Thank you.
The first training started in 2005, and by 2009, almost all the training was covered. The good thing here is it's not the responsibility of the federal government. Ethiopia has a decentralized system, and each regional government has a responsibility to manage those training activities. So the training centers even are within the different regions. So from the selection process to the training and deployment is primarily a responsibility of the regional government. In the initial training and deployment, the federal government supported the region because that was an initial initiation, but later on, for example, now salaries and all the support to the health extension workers either are in the regional budget or in the district budget. So in terms of continuity of trainings are there, first of all, for replacing attrition, but the current attrition is very low, but there is a plan in terms of the government to continue with continuing education, to upgrade them. So when they are upgraded, then there is a need to replace those who are going to the next level. So the schools which are called the technical vocational training schools are still there in each of the regions to cover those training activities.
Excellent, thank you. Thank you very much, and let us all give Mengistu a round of applause in our respective locations.
Thank you.
Thank you very, very much, and again, congratulations on the good work that you are doing. We are going next into a discussion period where we hope to use the, what is it called? Illuminate technology to the fullest, and we encourage participants in this webinar to offer comments by raising your hand and being recognized by the moderator. I think that would be Chris in North Carolina, or Jim here, and then offering a verbal comment or intervention that we hope everyone can hear, or continue to use the chat box to pose questions or make comments, and those of us here can respond to those. So should we give the technology a try and see who wants to offer a word or two? And we'll see which microphones. Would the microphone light up?
Okay, this is Chris in Chapel Hill. Aaron, do you want to go ahead and speak? I'm thinking you might be on the conference line because I don't see a microphone icon for you. Do we know if that's the case? Okay, in the meantime, let's go to Noreen. Noreen Hooney, you have your hand raised as well. Go ahead and click on the microphone icon in the lower left-hand corner of the screen and enter your comment, please.
Thank you for the very informative presentation. I just want to comment on the Ethiopian example and say the community ownership, the involvement of the multi-sectoral cadres, for me, comes out as a key issue for success. I can't agree with others more around the issues of quality. And my question would be, what are the follow-up in-service kind of trainings that these cadres receive after the initial training? And then secondly, just to say, if resources are directed, if financial resources are directed to the affected ministries, most of these models would give good results.
Sorry. Would you be kind enough to repeat your question or your comment?
The example from, I don't have the microphone, it's still there. Where is it?
Yeah,
Hello? The example from Ethiopia, community ownership and inclusiveness of multi-sectoral partners, for me, resonates as the key element for the success. The issue of quality is crucial following the trained cadres, just to find out whether they have ongoing in-service trainings to ensure they sustain the skills learned.
Thank you very much, Noreen. We heard you loud and clear. Now let's just entertain additional comments and questions for the next couple of minutes. So please kindly raise that little hand, and whoever is recognizing people,
Chris, are you taking the questions in order?
Sure. So right now, Kaweka, you're first in line. If you want to go ahead and speak, please.
Hello, this is Uganda. Okay, if you hear Uganda, the training of 34,000 health extension workers is attracted a lot of discussion in the room here, and we are wondering what the cost of the training and maintenance of those 34,000 extension workers in Ethiopia has had on the overall national health budget, and where the sources of financing has it been the national health budget of Ethiopia, or was it development partners that financed this? And what are the implications?
That's a question that Mengistu can address. So we've got 2 or 3 questions going. Let's take a couple more. 2 more.
Okay, Cote d'Ivoire, you are next. If you have a microphone, go ahead and click that to enter your question, please. Okay, you've entered your question in chat form. Jim, are we just going to collect additional questions, or does anyone want to?
We'll do one more besides this one, and we'll come back to that. This one was, we have a mothers to mothers and pilot fathers to fathers approach in PMT-CT, and while having positive deviant families in the community sounds interesting, we're not sure if it's expensive in non-prevalence areas. Okay. Let's take one more. This would be from number 3 from Elizabeth. I think it's Elizabeth Lema in Tanzania.
Okay, next up is Mwaba Bota. You're next in line. If you would like to go ahead and click the microphone button and enter your comment, please.
Hearing anything, so we'll go ahead and address some of the questions that have come up. The first question came, and it was about the meeting in Geneva about and the question is, how do you advocate for workforce strengthening, especially with different kinds of cadres being included without encouraging a sort of verticalization? And I think that has been an issue that the HRH field has addressed more or less successfully over the past 7 or 8 years. And I think one of the issues is trying to, in groups that are working together to advocate for change, whether at the global level or at the country level, it is by including people who are in charge of more vertical programs in with all of the other intersectoral groups, so that they realize whether it's family planning or PMT-CT or whether it is logisticians and trying to get the supply chain people more professional, so they realize that they have a stake in making sure that they have adequate numbers that are well supported and well hired. Because often they're just focused on the more narrow aspects of their particular program or disease that they're addressing. And so it's kind of engaging them as stakeholder groups to try and raise their consciousness and make them contributors to HRH strengthening areas. So that's one response to that. A second question, and I would throw this over to Mengistu. Mengistu, there was a question about what's the cost of doing the training in Ethiopia and who financed it. Could you shed a little light on that?
Okay, thank you so much. I'll try to make it brief. In terms of one of the questions related to quality, there is an in-service training going on after the graduation of the health extension workers. Even since most development partners were interested in supporting that one, there was like several trainings going on, which even was a challenge. But the ministry with the development partners sit down together and develop an integrated refresher training material for those areas which needs to be given as an in-service training. So any partner cannot go with different material. So the integrated refresher training material, which is standardized by the government with partners, will be used for improving the quality. But beyond the training, the actual monitoring from the health center and the follow-up during their activity is an important thing which is going on. I don't have right away figures in terms of the finance, but the training activity, there was a huge support from the development partners. But the ongoing running, I mean the salary and other activities are currently covered. The salary is currently covered by the government. It's not, it's fully covered by the government, but training and also there is a community support in terms of like the health post construction at the village level, providing certain support to start those activities. But the other things like equipment, the follow-up in service training, and also support to the training institutions was also done through the support of development partners. But we can get costs in future discussions.
Great. Thank you very much, Mengistu, and thank you for those of you who offered comments and who submitted questions and comments. I'm going to introduce Maury Mendenhall in one moment to wrap up. But before I do, just to say that I was sitting here thinking about Malawi in two respects, and I'm wondering if any friends from Malawi are out there. I think so. One is that when we were in New York a few weeks ago at the Global Partners Forum on Children and affected by HIV and AIDS, there was a delegation from Malawi at that meeting, and they spoke about an exciting effort in Malawi that sounds like what's going on in Ethiopia for the health workers. Malawi is embarking on a similar effort to strengthen the, I think they're calling them community child welfare or child protection officers. They've just added several hundred officers. They're adding them in increments as the government budget allows, and that's a very exciting effort. Maybe in the next webinar we can talk about that. The other connection I was thinking about Malawi as I'm introducing Maury. When I served in Malawi, the Malawi Tourist Board used the expression that, with all due respect to our other friends from African countries out there, that Malawi describes itself as the warm heart of Africa. The warm heart of Africa. Well, I would describe our friend Maury as the warm heart of our social welfare workforce strengthening group. She's doing a superb job. She's a dynamo. She's keeping this on track, and I'm about to introduce her to say a couple of words in closing, and thank you all very much for your participation. Maury?
Thank you very, very, very much, Gary, and thank you to our speakers today, but most importantly, thank you to all of you who logged in today and who were very patient with our various technical difficulties. This is our first, kind of our inaugural webinar, and I think we learned lots of lessons about webinars today as well. So I imagine that our webinars will only get better, and hope that you'll join us for the next one. Can we have the next slide, please? Just to give you a little preview of what's coming next, next month we have already selected another topic, and again this is based on feedback that we received during the conference about topics that were of interest to you, and also responses to the survey that was sent out. So during next month, and we'll send you information on when that webinar will be held and how to log on, we're going to talk about social welfare workforce training curricula, what's currently available, how to develop new curricula, and how to implement curricula. How is curricula used to train parasocial workers or social workers or just members of the social service workforce. There were so many excellent ideas that were shared today and excellent questions that were asked. And again, I just thank you so much for those questions. And we are sorry that we weren't able to address all of your questions during this webinar. We hope that we can, we will make note of all of your questions and hope that we can continue this discussion on ovcsupport.net. As a reminder, we will send out a link to this recorded webinar later on this afternoon. I'll send that out. Also, we're going to post that link on ovcsupport.net, and again, we'll make note. We'll try to transcribe some of these questions that you've asked, some of the answers that were provided, and then some questions that weren't able to be answered during this webinar session, we can hopefully answer through a discussion on ovcsupport.net. There were also some great suggestions about ways that we can make this webinar more useful to people, and these were offered during the chat, through the chat function. So I want you also to know that we made note of that as well. There was a suggestion that we send documents ahead of time so that people can look at those prior to the webinar, and we'll try to do that in the future. There was also a suggestion that we offer webinar sessions in different languages. So again, if this is popular, if people like these webinars, then maybe we could think about offering webinars to specific language groups in French or Portuguese or Swahili or Tigrian, Amharic, exactly. So those are my final comments. I do want to just remind you that I'm available. Everyone should have my email address by now to answer any further questions about these webinars. I also want to let you know that Dana Singleton, who was unable to join us today but has been really instrumental in organizing this first webinar, she's also available to collect your comments and answer your questions, and her email address is dsingleton, SINGLETON @CapacityPlus.org, and we'll send out her address later on today. One final thank you to Chris Horvath, who is an Illuminate genius, and he has been, I think, quite an educator today, and we all feel a little more comfortable with this technology. So thank you, and is there a final comment here? Okay, well, on that note, I think we'll log off. Thank you, and we'll talk to you next time.